Hi everyone, and in this video I'll be discussing an exciting topic, that is pharmacotherapy of glaucoma. How do we understand this? Yes, glaucoma is one of the common problem what we see in ophthalmology, and in this video I'll be discussing what are the drugs which we are going to use in the management of glaucoma. So first of all, what is the problem in glaucoma? The problem in glaucoma is there is a pressure inside the eye that is called intraocular pressure. So there will be increase in intraocular pressure. So what happens if the intraocular pressure is always high? That will put a back pressure on the retina. So that will lead to the retinal damage. So when the retina starts getting damaged, what happens later is the patient vision will become problematic. He will have a vision called tubular vision. So if you don't manage this, the patient will go for blindness. So the patient will end up with blindness. So the culprit here is intraocular pressure. The question is, where do you get this pressure from? The pressure is because of a aqueous humor. Now this aqueous humor is produced from a body called ciliary body. So ciliary body in the eye produces aqueous humor. And what is the role of aqueous humor? You all know that aqueous humor is required for providing nutrition for the lens as well as cornea. So when it is produced from ciliary body, it moves from the chambers, and after it is moving from the posterior to anterior chamber, from there it will be drained out. So there are two types of outflow. One is the trabecular outflow. There is a trabecular outflow, and there is one more outflow called uveo-scleral outflow. So these are the drainage pathways through which aqueous humor is thrown out from the eye and drained out. Again, it is synthesized, so it will come, it will go. So normal physiology, nothing will happen. The aqueous humor is produced from the ciliary body, and it will be drained out by trabecular outflow as well as uveo outflow. Now you imagine a condition. For example, a person is taking shower. So the water is coming heavily from the shower, and somebody has locked the room. So the water is coming forcefully, and the drain where the water is going, that is also blocked. So if the person doesn't do anything, he will be drowned in the water. So the water is coming forcefully, the drainage is blocked, somebody has locked the door of the bathroom. Now what he has to do is, either he has to stop the water coming out, or you have to open the drainage. Same thing is what we can do in glaucoma. Either number one, decrease the aqueous humor production. So decrease the aqueous humor production. That is one thing we can do. Second important thing is, you can increase the outflow of aqueous humor. So this is what we can do in managing glaucoma. So we'll discuss one by one. First we'll see what is the thing what we can do to decrease the aqueous humor production. You know where it is produced from? Ciliary body. So let us see that. The aim is to decrease aqueous humor production. So what are we going to do here? In this we have a receptor called alpha 1, alpha 2, then beta, particularly the beta 2, and also we have an enzyme called carbonic anhydrase. So they play a role in the production of aqueous humor. So if I want to stop the aqueous humor production, then I have to do something with these receptors. So let us see what we can do. So I will classify them like this: target A, B, C, and D. So what we have is alpha 1 agonist. Then what we have is alpha 2 agonist. Then what we use is the beta blockers. They are called as beta blockers. And then we have carbonic anhydrase inhibitors. So let me clarify this. Just we'll write it as beta blocker. I will explain the concept later. So The 4 drugs which decrease aqueous humor production are alpha-1 agonist, alpha-2 agonist, beta blocker, and carbonic anhydrase inhibitor. Let me go one by one. Number 1 is a alpha agonist, particularly the alpha-1 agonist. What is the name of the drug? The name of the drug is called dipivefrin. So it is called dipivefrin. It's an alpha-1 agonist. Now please understand, dipivefrin is a prodrug. Dipivefrin is a prodrug, and after metabolism it is converted into adrenaline in the eye. Now you may ask a question, sir, why can't we give adrenaline only as eye drop? The reason is adrenaline cannot cross the conjunctival barrier or corneal barrier and enter into the eye. So we need to give a prodrug called dipivefrin, which is converted into adrenaline. So what does adrenaline do? It acts on alpha-1 and it causes vasoconstriction. When it causes vasoconstriction, there is decrease in aqueous humor production. Obviously, when the blood vessel dilate, you can see the production of aqueous humor, but when the blood vessel constrict, the aqueous humor production decreases. So the major mechanism of action of dipivefrin is to decrease aqueous humor production by what? Vasoconstriction. So this is the major mechanism of action. Minor mechanism of actions, not the major one, the minor mechanism of action is it increases the trabecular, it increases UV scleral outflow. These are minor mechanism of action of the drug. Minor. But the major is this one. So once I know this, what happens sometimes on the conjunctiva, adrenaline can become a pigment called adrenochrome. So this adrenochrome will form a pigmentation on the conjunctiva. So patients taking dipivefrin, they complain a problem called the adverse effect of dipivefrin is conjunctival. Patient will complain of conjunctival black pigmentation. They will have this black pigmentation. So because of adrenochrome. So this was the MCQ asked in one of the recent exam. Please mark it. Which drug causes conjunctival black pigmentation? Along with that, another adverse effect that can be seen with dipivefrin is cystoid macular edema. So it can produce cystoid macular edema. So the name is called dipivefrin. That's the drug is. Let me move on to the second class of drugs. They are called as alpha-2 agonist. They are called as alpha-2 agonist. So what do? Alpha-2, you know that it is a GI coupled receptor. So it decreases cyclic AMP and thereby it decreases aqueous humor production. Not only that, it is also present presynaptically. So this is the synapse, you all know that. So this is the location of alpha-2. So by acting on alpha-2, you know that it decreases non-release. So that is also responsible for decrease in intraocular tension, that is pressure. So please remember, these are the mechanisms given in Goodman and Gilman, and particularly for INI-CT, these questions can come. That's why I am going in detail. Okay, so alpha-2 agonists are these 2 drugs. So what are the drugs in this category? We have 2 drugs. One is called apracolidine, and one more drug is called brimonidine. Apracolidine and brimonidine. Apracolidine can produce an adverse effect, that is lid retraction. So if I write A bar E, that is the adverse effect of the drug. The adverse effect of apracolidine is lid retraction, and brimonidine can cause anterior uveitis. But one important aspect is brimonidine can also cross blood-brain barrier, and because of that it can suppress the CNS, so it can cause CNS depression. So that is the reason, particularly in the children, it should not be preferred. The name is called brimonidine, and one more drug is called apraglutide. So these are alpha 2 agonist. The major mechanism of action I told you is to decrease aqueous humor production. Moving on to target number C. They are called as beta blockers. Block the beta, particularly the beta 2 in the ciliary body. It also decreases cyclic AMP, and that will decrease aqueous humor production. So what are the beta blockers we have? The beta blockers what we have is bitoxolol. Now the specialty of bitoxolol is it's a cardio-selective. The meaning is the bitoxolol blocks beta 1 more than beta 2. That's the meaning. Sir, will it block beta 2 also? Yes, but very less. Even with that, we can use it. The advantage, another advantage is bitoxolol also blocks sodium channel. Because it blocks sodium channel, it has shown to be producing neuroprotection effect. The neuroprotection is very important for managing glaucoma. The name is bitoxolol. After that, we have a drug called timolol. Now the timolol is non-selective beta blocker, and then other ones are cartiolol, and one more is called levobunolol. So these are what we call them as non-selective beta blockers. Now, one of the clinical questions what they ask you is, suppose a patient has come with bronchial asthma plus glaucoma, then will you prefer timolol or will you prefer bitoxolol? Is a commonly asked question in your exams. Now, what do you prefer? You pause the video and then try to answer. So, a patient having bronchial asthma and glaucoma, the preferred one is obviously bitoxolol. You know that cardio-selective beta blockers are preferred in asthma patient. Sir, when we put an eye drop, will that go systemically absorbed? Yes, the drug can also get systemically absorbed when you put it as eye drops. So there is a risk patient may get bronchoconstriction. So asthma plus glaucoma, the preferred one is bitoxolol. Otherwise, most commonly what we give to the patient is timolol. So what are the adverse effects with beta blockers? The adverse effect what we see with them is corneal hypoesthesia. That means decreased sensation in the eyeball, that is conjunctiva and cornea. Second important aspect is they can produce a problem called blepharoconjunctivitis. So this is the major adverse effect of beta blockers. The next target, as I was telling you, the D, they are called carbonic anhydrase inhibitors. They are called as carbonic anhydrase inhibitors. So their role is to decrease aqueous humor production. They also decrease aqueous humor. Now what are the drugs here? The name is called acetazolamide. The name is acetazolamide, which is given as the oral tablet in glaucoma. The other drugs are same thing, they end with zolamide, dorzolamide and brinzolamide. Now these drugs, they are given as eye drops. So one of the common adverse effects what we have seen with these drugs are they can produce two important problems. One is the corneal edema. It's not asked till now. Corneal edema. And one more important aspect is they can produce a taste difference, that is bitter taste. So patient may have bitter taste. So these are the problems with carbonic anhydrase inhibitors. So currently what I have discussed with you all is four important group of drugs: the alpha 1 agonist, alpha 2 agonist, the beta blocker and carbonic anhydrase inhibitors. Please remember, all these drugs are going to decrease aqueous humor production, that is synthesis. The second important aspect what we need to understand is increase the outflow of aqueous humor. So increase the outflow of aqueous humor. How do we do that? Number one, there is a drugs. What are the drugs? They are called as miotics. The drugs are called as miotics. What do? They cause meiosis, that means constriction of pupil. Now the miotics, they increase a outflow called trabecular outflow. Miotics, they increase trabecular outflow. And they are used in angle closure glaucoma. They are used in angle closure glaucoma. So what is the problem in angle closure glaucoma? The angle between, suppose this is the cornea and this is the iris, right? So this is the angle between the cornea and iris. This is called iridocorneal angle. So in angle closure glaucoma, this angle is closed. This angle is closed. So when you cause meiosis, the angle gets opened up. But when you cause mydriasis, the angle will close. So in angle closure glaucoma, remember, we use miotics to treat. What we contraindicate is mydriatics. So the angle will be opened by the miotics. So what are the drugs we use that miotics? The drugs are pilocarpine. Then we use an anticholinesterase that is called physostigmine. And one more older drug, it is called ecothiopate. So these are the miotics. Usually miotics are the first choice of drugs for angle closure glaucoma. But the treatment of choice for angle closure glaucoma is to remove that adhesion, to open that angle. That is the surgical management that will be dealt in ophtho. But drug wise, miotics are the first choice. So this is miotics for it. The second important drugs, what I am going to discuss, the drugs which increases uveoscleral outflow. So what are the drugs which increase this outflow, that is called uveoscleral outflow? They are called prostaglandins, PG. And what is the derivation? They are PGF2 alpha analogs. They are PGF2 alpha analogs. The name is latanoprost. And another drug called bimatoprost. Then trovoprost. So if you observe, all their name end with prost. They all their name end with prost. Please remember, these prostaglandins are the first choice nowadays. First choice for open angle glaucoma. So they are the first choice for a condition called open angle glaucoma, and they increase the uveoscleral outflow, and most commonly used eye drops in glaucoma. That's the reason they ask you the adverse effect of these drugs. Remember, you can remember the adverse effect by the mnemonic MIG. You know MIG, the jet, the fighter jet. So M for the macular edema. Macular edema. I for the iris pigmentation. The iris will become pigmented. And there is increased growth of eyelashes. Growth of eyelash is increased. So these are commonly asked in exam. Please mark it. Iris pigmentation is already asked. Macular edema is already asked. So another adverse effect which is still now not asked, they can also produce orbital fat atrophy. This is one more adverse effect which is caused by them, but is not asked till now. So we can expect that in the future exams to come. The MIG, macular edema, iris pigmentation, growth of eyelashes, latanoprost, pimatoprost, tropoprost. Now please understand one important aspect. Prostaglandins are inflammatory mediators. So they can cause inflammation. That's the reason they are contraindicated in inflammatory glaucomas. If there is any inflammation and glaucoma, for example, anterior-uveitis with glaucoma, we don't use it because they themselves can increase it. So they are PGF2 alpha. So their main action is to increase uveitis outflow. Now coming to the last important aspect, the newer drugs. We have newer drugs for glaucoma. What are the newer drugs? Number one, we have a drug by the name Natrasudil. The name is Natrasudil. So what does it do? It inhibits an enzyme called Rho kinase. So when it inhibits the enzyme Rho kinase, that will lead to vasodilation in trabecular area. So it will increase what outflow? It increases trabecular outflow. So recently this question had appeared in your exam. What drug increases trabecular outflow? It is Natrasudil. Any adverse effect with this drug Natrasudil? Yes, it has produced something called cornea verticillata. So that is one of the adverse effects what we see with the drug Netra. Netra means eye, Sudil. So it's an inhibitor of Rho kinase, and that will cause vasodilation, increases trabecular outflow. One more newer drug I just want to tell you, and that is called latanoprostene bunod. Now this is a drug made up of two things. One is latanoprost and one more, it is made up of a mononitrate. Right. So this latanoprost, it's a PGF2 alpha. It increases uveoscleral outflow. And mononitrate, it is called butanediol mononitrate. So you know that nitrates are vasodilator. They cause vasodilation in the trabecular area, and that will increase the trabecular outflow. So the advantage of this new drug is it can increase both outflows. The name is called latanoprostene bunod. So we understood the newer drugs. Many times we come across this question: what is the drug used for open angle glaucoma? What is the first choice? Open angle glaucoma, the first choice of drugs, yes, what is that? They are miotics. Is it so? No. Can you take a guess? They are PGF2 alpha analogs, that is latanoprost, pimatoprost, tropoprost. What about closed angle glaucoma? Closed angle glaucoma, the angle between the iris and cornea is closed, so the opening can be done with miotics like pilocarpine, physostigmine, ecothiophyte. The one more complication, the red eye, that is acute congestive glaucoma. What is the drug of choice? See, the pressure is too high and you have to decrease it as fast as possible. So what we use is mannitol. That is the first choice what we can use, mannitol given IV. So that is the first choice. If it is not available, then we can use acetazolamide. So first choice is that one, mannitol. Now what is contraindicated in angle closure glaucoma or closed angle glaucoma? Yes, what is that? Don't use mydriatics. I'll just give certain examples. For example, atropine or anticholinergic drugs should not be used. And the drugs which are used in CNS which have this property, they are called TCS, tricyclic antidepressants. They should not be used, for example, imipramine. So this is the summary of what are the drugs used for glaucoma. So in this video, guys, I explained to you what is glaucoma. There are two types, open angle and closed angle glaucoma. The open angle glaucoma, here the angle between the cornea and iris is open, but the problem is drainage is blocked. Closed angle glaucoma, the angle between the cornea and iris is blocked. So what is done is surgery, or you can do myotics. The problem in glaucoma is the intraocular pressure is high. And how do I decrease it? Either decrease the production of aqueous humor or increase the outflow. Please remember, there are 4 drugs which decrease aqueous humor production: the alpha-1 agonist, epinephrine, alpha-2 agonist, upregulatin and brimonidine, then beta blockers, betoxolol, timolol, and carbonic anhydrase inhibitor, the envafolimab. Then we have the drugs which increase the outflow. The trabecular outflow is increased by myotics. The uvascular outflow is increased by the prostaglandin F2 analogs. Most of your exam questions is on the adverse effect of prostaglandins, remember as MIG, macular edema, iris pigmentation, growth of eyelashes. Newer drugs are letrozole, which increases trabecular outflow, and one more is latanoprost and Bunod, which can increase both the outflow. So that's it in this video. Thank you all.